Hello, good afternoon, everyone. This is Dr. Suraj. I am a urologist and an andrologist with around 5 years of experience in this field, and I have been working at Fortis Hospitals, Bannerghatta Road, Bangalore. I have been operating on patients with renal stone disease and ureteric stone disease since the last 5 years with various modalities to operate on, including multiple procedures from ESWL, the OPD basis procedure, to RIRS, PCNL. I'll explain through all these procedures as we go along. Um, so, coming on to the topic today, the hard truth about kidney stone disease. So, let me put across one important fact that kidney stone disease or the stones in your urinary system is one of the most common causes of a patient reaching out to a urologist. So, the pain which is associated with the renal stone or the ureteric stone is quite severe, and most patients convey it to be so severe that it is equal to a pain which is associated with pregnancy. So people do come and ask us that, sir, we have stones in our kidneys or stones in the ureter. How do we think? I mean, what are the symptoms? How do we diagnose it, and how do you treat it? So let me put across first about the etiopathogenesis of a stone disease. So the first thing. So, kidney stones are most commonly or very commonly formed in patients who are dehydrated, that is, who take in a little less water compared to the routine population. So, let me put across the statement saying that it is mandatory that we at least have an intake of around 2.5 liters of fluids per day. If you are a person who hits the gym, sweats a lot, or a worker who works more in the sunlight and tends to get dehydrated, add another 500 to 600 ml. So that should be our minimum intake of fluids per day. So that is one of the fact. And second thing, it is about our dietary components. Foods which are rich in oxalates, especially the tea, coffee, including the green tea, the black coffee, and lot of soft drinks, they contain very high oxalate containing foods, so they tend to cause stone diseases. And coming on to stones which are caused by uric acid, these are predominantly seen in patients who are non-vegetarians and consume a lot of seafood and also red meat. So these are the most common causes of stone disease on by per se. And eventually there is another thing, that is there is some genetic proneness. So genetic proneness in the sense, I wouldn't say that, sir, my dad did not have stone disease, my brothers do not have stone disease, but I do have. It is not always that it is carried from father to the son in that way. Genetic means basically that is how your body is constituted of. So like you're fat, thin, well built, tall, fair, that is how your body was made to produce stones as well. So these are the causes which eventually cannot be completely cured, but your risk for stone formation could be reduced. uh, yeah. So these are some of the common causes of stone disease. So usually the common presentations to us when the patient comes with renal stone or a ureteric stone is, patient come with pain in the flanks or the lower back. So this is usually radiating to the side with which the obstruction is there. So if you have a right sided or right flank pain, so the stone is usually on that side or the blockage happens on that side. So that is how the stone is actually, it is not at the center or the midline or in the vertebral column. So usually patients with low back ache in the middle of the back, that is around the vertebral column, come with saying that, sir, I might have a stone. No, this is more or less not a stone pain, but it is more or less because of your spinal cord issues rather than your stone related issues. So these are usually lateralized. Though coming on to the second thing, that if there is a blockage of your urinary system by a stone in your ureter, so basically the kidneys are connected to the urinary bladder, which is the storehouse of urine, through a small tubes called as ureters. So any urine which gets blocked in these ureters because of the stone causes stretching of the kidney and severe pain on that side. So once there is a blockage of the kidney, there can result in infection and also severe pain. So once kidneys are blocked, they tend to give very severe pain, which tends to give rise to vomiting and also nausea. So the common presentations would be flank pain associated with nausea and vomiting, and the third thing would be presence of fever. So a blocked system isn't where the urine is getting stagnated, tends to get infected, and patients might present with fever and chills. So these are the common presentations. So once you see a urologist with these complaints, the first investigation he would be asking for is a urine routine test and an ultrasound of the kidney, ureter, and the bladder. So, in the kidney, ureter, and bladder, the renal stones can be well picked up, but most of the time, the stones in the ureter might not be commonly picked up. The reason being, there is I mean problem with the ultrasound waves when there is gas that comes in between. So if the intestines come in the way of your ureter, the ultrasound waves cannot travel through the gas, so your ureters are not well visualized. So usually the reports would come something like there is dilatation of your kidney and there are few stones in the kidney, but ureter could not be well visualized. Or if there is no obstruction to the view of the ureters, they might say that there is a stone in the ureter measuring so and so size. So then the doctor would always ask you for getting a non-contrast CT. So non-contrast CT is the investigation of choice. So I would like to highlight in here because most patients do come and ask, sir, ultrasound is already there. Why do you want to get a NCCT again? See, ultrasound, why ultrasound is done on the first place? See, ultrasound is less cost, and second thing, it is there is no radiation exposure and it is completely safe. So it is used as a screening tool. So with the screening tool, when you have the suspicion that it is definitely a ureteric stone or a renal stone, then you go to confirm it with a CT scan. So in the CT scan, you get lot of information. More importantly, the exact location of the stone, the exact size of the stone, how badly it is obstructing the kidney, and also the hardness of the stone. So in the CT scan report, the radiologist mentions something called as HU or Hounsfield units. So this describes the hardness of the stone. So basically, this helps us in diagnosing and try to plan the management, which type of energy source or the procedure I want to use for breaking the stones. So I'll tell those again when I come to describe the different types of procedures. So coming on to the next point, so once the CT is done and we have a diagnosis of a ureteric stone, so next comes what is the line of management. So if the patient is having an active UTI, urinary tract infection with urine routine showing suspicion of infection or their urine culture is positive, then we always advise we'll only be stenting the patient and bypassing the stone and probably do the procedure of stone removal at a secondary stage and also treat him with IV antibiotics. So, and especially in patients who are diabetics, we do not go ahead with removal of the stone in the same setting because there is increased risk of septicemia and also multi-organ dysfunction later on. So we tend to stop it at that stage and do what is the most necessity at that point of time, that is diversion of the urination. So urinary diversion. So this will relieve the pain, relieve the obstruction of the kidney, relieve the infection, keep you safe. Stone can always be dealt the other day. So that is what is most commonly done when there is signs of infection. There is no signs of infection. Urine routine seems to be fine. Culture is negative. Patient doesn't have fever or isn't febrile. Then we go ahead with management of the stone. So coming on to the management of urinary stones. So even though it is mentioned as kidney stone disease, I would like to include all the form types of stones which are formed in the entire urinary tract. So stones could be are usually formed in the kidney, which drop down into the tube called as a ureter, and then drop into the bladder and then pass out. So stones which are formed in the kidney. So if when they're developing, usually the stones in the kidney give you a very vague back pain or a flank pain rather than a severe kind of a pain, because in the kidney, small size stones do not block any part of the kidney. So once there is no blockage or obstruction, there wouldn't be such severe pain. So usually these stones are not like an emergency to be treated, but if they are of a bigger size more than 1 centimeter or even 7 mm, they need to be treated. The reason being, if it is anything less than more than 6 to 7 mm, the chances of those stones any day falling into the ureter and blocking the ureter becomes higher. So we cannot estimate when the stone falls into the ureter. Definitely no, it can fall the next day or never fall also. But the chances of it blocking the ureter are higher. So such kind of kidney stones need to be treated. And any stones in the ureter which is more than 6 mm needs to be treated, because usually Indian adult male ureters tend to pass stones of size 5 to 5.5 mm. So people have passed even 1 centimeter stone, and there are people who have not passed 3 mm. This is on an average. So anything more than 5.5 mm stone, and the pain is recurrent over the last 48 to 72 hours, so then it is better to treat it surgically rather than wait with medical management. So coming on to the treatment options, so coming to the stones which are there in the kidney, so these can be dealt with non-surgical and surgical line of management. So smaller stones of around 7 mm or even up to 1 centimeter, which are softer in consistency. So this is where CT comes into play. When the CT shows a Hounsfield units of less than 900, that means they are softer stones. So softer stones and smaller than 1 centimeter, you could go ahead with non-surgical management called as extracorporeal shockwave lithotripsy, that is ESWL. So the commonly called by a layman as shock therapy over the kidney, which breaks the stone from outside. So basically it is an ultrasound wave which is used to break the stones from outside. So it is done non-surgically in the OPD. The idea is to use ultrasound waves to break the stones into tiny pieces, and these pieces pass off. The problem with these are, if it is harder stone, it cannot be used. If the patient has bleeding issues or bleeding diathesis, it cannot be used. In a pregnant woman, it cannot be used. And on the third thing, the other issue is these small fragments may invariantly get stuck in the ureter or get blocked in the ureter at times. So these are the issues with ESWL, but it is a non-invasive or a non-surgical technique. The other technique which has been found to be more commonly used these days is something called as RIRS, retrograde intrarenal surgery, where a flexible scope is taken from the urethra. So urethra is a place from where we void urine. So the scope goes in from there, goes into the bladder, goes into the ureters, and then into the kidney. And using laser, we dust and fragment the stones, which are into tiny particles, and then place a double J stent. So stent is a polyurethane material, very similar to a plastic material, which is placed between the kidney and the bladder. So this allows the dust or the finely fragmented particles of the stone to pass out, allows the infection to heal, and also allows that ureter to heal post surgically. So it is a commonly add-on procedure for all the stone removal procedures in the kidney and the ureter. So RIRS deals with it. And coming on to the other procedure, which is called as PCNL. So PCNL is percutaneous nephrolithotomy, where the puncture is taken from your upper back just at the level of your kidney, and directly enter into the kidney, break the stone with laser or pneumatic lithoclast, and you remove the fragments. So most of the patients, they do their research and come to us and ask us, sir, is RIRS better or PCNL is better? Again, the decision is made by the treating physician or the urologist, based on the hardness of the stone and size of the stone. Very hard stones, very huge, big size stones around more than 2.5 centimeters, PCNL becomes the surgery of choice. Because in RIRS, so usually the amount of indwelling time inside the kidney is around 1 hour. So you cannot usually complete breaking a 2.5 centimeter or more bigger stones in 1 to 1.5 hours. So by doing this, there is an increased risk of infection. But at the same time, RIRS has less bleeding chances, less painful. But PCNL is slightly more painful, higher risk of bleeding, but less risk of infection. So this has to be weighed based on the size of the stone and the hardness of the stone, which the consultant urologist would be recommending you. So based on that, each takes an opportunity. I mean, upper hand over the other. So usually, I in my practice have been always following PCNL for stones which are more than 2.5 centimeters and very hard stones, and anything less than 2.5 centimeters and softer stones for RIRS. Coming on to the stones in the ureter, so they can be in the upper ureter, middle ureter, or the lower part of the ureter. The standard procedure for these cases would be something called as URSL. So this is ureteroscopic retrieval of the stone. So this uses a rigid scope to enter into the urethra through the bladder into the ureter, break the stone with laser or pneumatic lithoclast, and place a stent. So this is a very commonly done procedure for ureteric stones. This releases the obstruction of the ureter and also helps the kidney to heal. So URSL is the standard procedure for ureteric stones. Then coming on to the stones in the bladder. So again, depending on the size and hardness of the stone, we go ahead with laser cystolithopaxy, or you go ahead with cystolithotripsy, where you break the stones and remove them. Okay. So if the stones are too huge or too big, then we do something called as PCCLT, where a percutaneous approach is taken into the bladder and the stones are retrieved. Or if the stones are very big, or if the stone is very big, of the size of 5 centimeters, the largest I have operated is around a 8 centimeter stone in the bladder. So we retrieve it on by open surgical technique. That's a commonly advised procedure. So once we do a procedure and place a stent, usually these stents are placed between anywhere between 2 weeks to 3 weeks, and after that the stent is retrieved. So next, doctor, what is the way that I can prevent further stone formation? Already I have been put into such lot of pain and I mean, money also investing on the healthcare. So, what do I do to prevent newer stone formation? So, any person who has formed a stone is always at a risk of recurrent stone formation by around 50%. So, you are always tend to you are bound to develop a stone. The most important thing is to hydrate yourself. We think we are drinking water. We know that we start drinking good amount of water after a surgery, but always quit it after around a month or so. But if a person manages to make it a habit to drink around 2.5 to 3 liters of water, there is a reduction of around 30% from that 50% in risk of stone formation. So that is very important. Reduce on your salt intake, especially salted items, salted pickles, papads, peanuts, and also foods that are processed, especially from outside. So cut down on them. Reduce on your non-veg intake to weekly once, especially the red meat, and reduce on your reduce or definitely quit drinking sweetened drinks, whatever it may be, from Coke to Jaljeera, whatever it is, all are sweetened drinks. All of them contain a lot of oxalates. So there is nothing better or nothing worse compared to them. So all of them can be high risk feature. And people do ask me, sir, should I quit tomato? Should I quit cabbage? Should I quit turnip? And all these things. See, these foods have been found to have high oxalate content. Yes, they have been proved medically and have been listed in the paper. But tell me, any South Indian or any Indian for that matter diet, can a food be cooked without tomato? And the amount of tomato or anything we use is not so high quantities that it causes a stone because of that. So I wouldn't recommend that you quit tomato, quit onion, quit cabbage, and all these things, because it's impossible, and you tend to come back to those. So that is not a very major thing which I would suggest. So there would be some patients who would say, "Sir, I have already had three stones. Now I might be developing a fourth stone. What should I do?" So these are called as recurrent stone formers. So recurrent stone formers usually are the patients who have some form of metabolic abnormality which needs to be diagnosed and picked up at the earliest. So if you are a patient who has developed stones more than twice, or if you have multiple stones in your kidneys, or a child who has developed a stone, or patients who are having other metabolic issues, then you need to get yourself evaluated for metabolic diseases which can form stones. So this is called as metabolic evaluation, where once you are free of stone, like you have been operated now, you have been cleared of all the stone diseases, then after 21 weeks your stent is removed, and after 3 weeks from there, so 6 weeks after stone free rate or becoming stone free, you can you can undergo this metabolic evaluation, where 24 hours of your urine is collected in a bottle, and that is analyzed to risk check for various other issues like your uric acid levels, oxalate levels, and calcium levels, potassium levels, and also your hydration status. And based on this, your metabolic abnormality could be picked up and henceforth treated accordingly, to see if you're having primary oxalosis and other things. So it is the part of the urologist to do that and explain it to you accordingly. But I would like to recommend all patients with recurrent stone disease to undergo a metabolic evaluation to prevent recurrent stone formation. Okay. So I think I have covered most of the things in brief and collective manner, and I would like to answer if there are any questions, and put forward more information in pertaining to those questions again and again. Yeah. Hi Apurva, you are there? Hello.
Yeah, yeah.
Okay. So I'll go ahead with the question and answer seminar. I mean part.
Yes, please.
Okay. Do we need to do surgery for kidney stones, or it can be removed naturally? Yeah. So that's what I was trying to tell you. Kidney stones of the size less than 5 mm can be treated medically. Um, and anything more than 5 to 6, 7 can be treated with non-surgical management like ESWL, and anything more than 7 to 8 the risk of them being treated, medically, and would be lesser. So let me put across this statement, that most of the stones which are there in our body cannot be reduced in size or melted down there in the same location. So there are many people who take in medicines from Ayurveda, or some quacks also to that matter, saying that a pillow or your stones will melt out there. At least by medical research, and the present studies, except for uric acid, none of the other type of stones cannot be melted down there. Only uric acid stones can be melted down there with very strict diet, and also alkalinizing the urine, that is making your urine more basic rather than acidic. So this can be possible for only uric acid stones. So rest of other stones, you can only prevent them from growing further by changing your urine pH, diet, and other things. So you cannot melt your stones, but you can pass out the stones. So once the stone falls into the ureter, there are some medications which we usually prescribe if it is less than 5 to help it pass out easily. I go to washroom very frequently, and what is the issue? So basically, frequent voiding is something called as urgency. So urgency comes under something called as storage symptoms. So this is not related to kidney stone again. So, but because the question is asked, let me put across a few words. So any issues with your voiding, that is passing of urine, can be divided into two groups. So one is the storage lower urinary tract symptoms, and the other is the voiding lower urinary tract symptoms. So urgency, frequency, and nocturnal urination, they come in storage symptoms. Excuse me. So storage symptoms, when they are there, there is some form of irritation to the bladder which is being caused. So it could be either infection, or it could be either because of the various medications or foods which are taking, which could be bladder irritants. It could be because of what do you call as overactive bladder, which is idiopathic, especially in women. It could be something related to anxiety or stress, so stress related depending on your work. So all these causes, and including very rarely malignancies or tumors, can also present with overactive bladder. So increased frequency is because of overactivity. Because of any of these issues, we need to diagnose based on further more detailed history and also evaluation. So most commonly in women with frequency and urgency, the first thing to rule out is infection, urinary tract infection, which is a common thing. My son, 34 years, got stoned twice. What precautions are required to minimize stone formation and extract automatically? So, extract automatically is not possible if the stone is more than around 7 to 8 mm. And yeah, minimize stone formation. As I told you, hydration is the most important concept. And also, as I put forward, so many diet restrictions which need to be followed up. And if your son has got twice, then definitely it's a mandate that he undergoes a metabolic evaluation for stone formation. He could be suffering from one of the metabolic issues, which, when corrected, he might end up with no stone formation then onwards. So it is, if he has already the third stone, as you're commenting, extract automatically, I think he might have more stones which needs to be evaluated. How can we naturally cure kidney stones? There is nothing called natural cure. You can only prevent it with, as I told you, some of the measures which I put forward at that point of time. Please tell about post care kidney stone remove. I did not get this question. Post care kidney stone remove means. Could you elaborate, someone, if you can? Question number five. What is the process of kidney stone removal? Yeah, as I told you, it depends on the location of this stone and also the size of the stone. If they are smaller and if they are softer, then RIRS is the newest modality, which uses laser and flexible scope to fragment the stone and dust the stone. It's a daycare procedure, and you will be discharged the next day morning, and you can be off to work in a day's time. Okay. And if the stones are bigger, then PCNL would be the choice, requiring a little bit of bed rest of around 7 days. Okay. And please tell what all precautions one should take care after going through a kidney stone removal surgery. So again, it comes in the comes into a thought process where what type of surgery has been done. URSL and RIRS are very, very minimally invasive procedures, so there is no much restrictions after a procedure with these question. With these surgeries, there is no much restriction. So usually you can assume your very normal activities the next day. The only thing is, because of the stent in position, a stent being a foreign body could be a slight irritant to your bladder, causing a little bit of urgency and want to void again and again. So that might be a little disturbing thing for patients who would like to get into office and stick to their work. But apart from that, there is no strict restrictions on your day-to-day activities. Definitely no. But for PCNL, where you have punctured the kidney to reach the stone, So it is recommended that you don't get into physical exercises like lifting heavy objects or going to the gym for at least a month. So that is the only precaution. Apart from that, good amount of water intake should prevent stone related symptoms, and the medications which will be prescribed for around usually 5 days, covering your antibiotics with to prevent post operative infections, should be the only thing that is required, nothing else. So I think we are done with the question and answer session as well. Okay, let's end. So I'll leave the this thing chat, or should I? You would be doing it, Apurva. Okay. Uh, okay, then I think we are done. Bye, and thank you for your patient listening. And I hope I've answered most of the questions related to the kidney stone disease, and I think good amount of information